Hi everyone, my name is Ryan Howard. I'm a surgery resident at the University of Michigan. I want to thank SAGES for the opportunity to present our work looking at hospital level variation in mesh use for ventral and incisional hernia repair. Thank you. I have no disclosures. So as we know, the use of prosthetic mesh in ventral and incisional hernia repair reduces the incidence of postoperative hernia recurrence. This is based on very strong evidence, including randomized trials, showing that mesh is superior to primary suture repair alone in preventing recurrence. As a result, there are multiple consensus guidelines that give strong recommendations for using mesh in virtually all ventral hernias in a clean surgical field. Despite this, it is unclear whether current surgical practice reflects this. We know that just because something has strong evidence behind it does not always mean that that evidence is aligned with practice. So we conducted a study to understand what's the variation in mesh use between hospitals, and is that variation associated with differences in hernia or operative characteristics at those hospitals. For example, we might assume insofar as mesh is going to be used in larger hernias and for minimally invasive repairs, it may just be that the hospitals using mesh more often are managing larger hernias and doing more MIS repairs. So it was these kind of associations that we were specifically interested in evaluating. To do this, we conducted a retrospective study using the Michigan Surgical Quality Collaborative Hernia Registry. This is a data registry that we launched in 2020 to better study ventral and incisional hernia at a population level. It includes cases from 70 hospitals in Michigan, and it relies on a synoptic operative note to basically capture granular details like hernia size, where is the hernia, what kind of mesh gets used, and patient characteristics and clinical characteristics as well. Cases are randomly sampled across the state rather than voluntarily submitted. And for the current study, we focused on adult patients undergoing clean elective ventral hernia repair over the past 2 years. Our primary outcome was hospital level mesh use. And for the analysis, we used risk and reliability adjustment to control for measurements that were clustered at the hospital level. And then we evaluated the association of each hospital's overall rate of mesh use with their operative and patient characteristics at the hospital. Our cohort was just over 5,000 patients, half of whom were male, with a mean age of 54 years. The mean hernia width was 3.2 centimeters. 40% of cases were performed minimally invasively. And we were ultimately able to include data from 65 different hospitals across the state, where case volume ranged from 10 cases to 229 cases, with a mean of 81 cases at each hospital. Overall, mesh was placed in 77.9 of the hernia repairs, and this chart here shows at the patient level, as we expected, the two factors most strongly associated with mesh use were hernia size and surgical approach. So we can see as that the probability of mesh placement after adjusting for all the other clinical differences between patients in terms of how sick they were, et cetera, we can see that as hernia size increases on the x-axis, the probability of mesh placement increases on the y-axis. And then also, as we expected, the likelihood of mesh placement dramatically increased when going from open to minimally invasive repair, which is represented in that orange line there. This chart illustrates the overall rates and 95% confidence intervals of mesh use at our 65 individual hospitals. This is kind of the meat of the study, so I'll walk through this chart. So the x-axis here is each of the individual 65 hospitals, just ranked 1 to 65. And the current values displayed are the overall mesh use at that hospital on the left y-axis from 0 to 100%. And as we can see, this ranged from 38% at the hospital with the lowest rate of mesh use for ventral hernia repair to 96% at hospitals with the highest rate of mesh use. So already, this told us, there's striking variation here. There's a twofold difference from the lowest mesh utilizer to the highest mesh utilizer. Next, we looked at hernia size. That is on the right y-axis here from 0 to 7.5 centimeters. And we fully expected to see a similar trend, that as mesh use increased, hospitals would be managing larger hernias. However, this was not the case. The blue dots here represent each hospital's mean hernia size. And it's fairly easy to see there was actually no association whatsoever with the hospital's hernia size and their mesh use. And in fact, if we focus on the very top and bottom hospital, I'll point out, we can actually see that at the bottom hospital, they had a larger average hernia size, 3 centimeters, than the hospital that used mesh in almost every single case, where the average hernia size was about 2 centimeters. We also looked at each hospital's use of MIS repair, and again, we found no association. So that's the red dots here, I hope they come through, of MIS use from 0 to 100% of their cases, and same thing, no association with how often these hospitals were using mesh. In the end, we actually found that there were no patient or operative factors that were associated with variation in mesh use between hospitals. I know this table here is super crowded, but I only present it to illustrate that we looked at about 24 different factors, including patient comorbidities and operative characteristics, and none of them were significantly associated with hospital mesh use. So this type of variation, especially at the hospital level, is a common target for research. There's been plenty of studies that have evaluated variation in mortality, failure to rescue, use of different surgical approaches between hospitals, and other processes of care. And I think importantly, this is often the first step to informing quality improvement efforts to reduce variation and better align practice with the best available evidence. But I want to also recognize it's important to note that this really is only a first step. You know, in the current study, for example, we are still left with no answer to what's driving the variation we saw. You know, is it what's in stock at the hospital? Is it the preference of the, hernia group there, et cetera? So I think we need to dig deeper using these data to kind of understand what is driving this variation. But I think the current results give us a really good roadmap to do just that. So just to summarize, we found that despite strong evidence supporting mesh use for ventral and incisional hernia repair, there was really dramatic variation in mesh use between hospitals. And importantly, this variation was more or less arbitrary. It was not associated with differences in hernia size or surgical technique at these hospitals. So I think that this tells us that there are opportunities to standardize surgical practice to better align with the best available evidence. And doing so could certainly help improve the care and outcomes of patients undergoing this operation. Thanks so much for your attention, and I'm happy to take any questions.